Thanks, Renee. Thank you, everyone, for coming. Thank you for the invite to speak. There are many familiar faces in the audience. Please feel free to interrupt whenever you'd like. Needless to say, I didn't read the brief. So when they said you had to present a PowerPoint, I'm not presenting a PowerPoint. So while we're being set up, I'll quickly tell you about the history of the clinic, where we are now, and our vision for the future. So the clinic's been running since late 2014, early 2015, so pushing on 8 years. We started with 4 of us, including Nat, who was in the room. There's now a lot more people in the clinic. There's Kylie, who's in the room, who runs the clinic, so thank you, Kylie. We have me, a paediatrician, a geneticist, a number of fellows, a plastic surgeon. We have same-day eye clinic as well. We have same-day neuropsychology. We've got the transition team, and Jamie's going to speak to you next. And we're well integrated with the adult service at the Royal Melbourne Hospital, and we run a transition service and a transition day once a year. So that's the day-to-day clinic. The model that we've really embraced is a clinic which is very patient-focused. We want to be a one-stop shop, so someone comes in with a problem or with NF, whether it be NF1 or NF2, and we want to offer the complete service in the one clinic. So rather than having to find your specialties and your services in other parts of the hospital on different days, we want to be able to make it a one visit and see as many as 5 or 6 different services. Hopefully we're doing okay. If we are, it's thanks to Kylie, and if we're not, it's because of me. So as the years have grown, as has our clinic, we're well aware that many of our patients require general paediatric follow-up, and they weren't accessing it in the community. And so we brought in a general paediatrician, and Dina, who'll speak to you later today, has been with us for a couple of years. And over the next really year to 2 months, I really look to expand out that part of our service, because as soon as we started offering general paediatric care, and that's for the symptoms of ASD or ADD, other behavioural problems, that service was full. So now Dina's wait is pushing out to 6 to 12 months. That was correct. So we've found that with our model of care, as soon as we offer a service, it becomes full. And so as we go forward, we hope to continue to grow, knowing that growth has a limit. But that is a problem that we're a long way away from. The team from Royal North Shore is not here today. They spoke yesterday about how they've really expanded out their service to be a statewide service in New South Wales, and that's a model that we aspire to copy. So that's what we're going to aim for as well over the next 12 to 24 months. I won't speak about the research we're participating in. You can find that on the website if you Google it. But what I'm going to do is, you've heard a lot from us. I'm going to run a poll. So if you look on the screen now, if everyone pulls out their phone, you need to actually do this. I hope this works. This is very beta. That should come up. That should take you to a link. That should take you to a link. And if you're at home, you can do this as well. If you can skip the name. I don't much mind if you put a name in. If you are doing this at home with one device, this is not going to work. If you're doing this at home, it will work if you have 2 screens, or you use Windows the way it was designed and you divide it into 2 windows, or just use your phone to... So has everyone got a screen that looks something like this? Okay, so this is just a warm-up question to see if this works. Oh, I can't. Here we go. Okay, so could everyone just tell me who is going to win the grand final? And this is for all the Victorians in the room. Well, anyone who lives below the what's the line? The Ron-Barassi line. Below the equator. So yeah, I think it's called the Ron-Barassi line. I learnt about this a couple of weeks ago. This has been a source of much academic interest. There's a line in Australia which is like from the top of WA that comes down to around where Wagga is. And if you live below that line, you follow AFL. And if you live above that line, mysteriously, you follow rugby league. Okay, so There are clearly some delusional people in the room. It's going to be a number of decades before Carlton wins another grand final. So it seems to be working. I don't have absolute numbers. I'm a Richmond fan, only because the AFL stole Fitzroy and moved them to Brisbane, and with that lost my following. Okay, so you all know how this works? Oh, I think I need the arrow to progress the slides. Okay, so the next question. How far did you come to travel here today? So it should be on your phones as well. I forgot to put in the option, I am on my couch, for all those people at home. But I guess you can all say that you've come less than 20 kilometres. Now, this question was going to be the warm-up question until I put the other warm-up question in. And the reason I put it in is because we know that a lot of our patient population do not live in metropolitan Melbourne, and they do live in the regions. And Carly's done a heat map for us about where patients come from, and that we know that there's a big group of patients who live up near Albury, and a group out in Gippsland, a group out in Warrnambool, and we know that in coming to Melbourne for clinic might be good once every year or two, but coming to clinic every time there is a clinic is often going to be really difficult. Before we go to the next question, I can go here are the responses. So most people, I don't have absolute numbers, but most people have come less than 20 kilometres, which means they're probably sitting on the couch. A few people have come from the outer urban areas, and the people who have come from up to 400 kilometres are likely Victorian, and the ones that more than 400 kilometres are either from Sydney. Welcome. Next, please. Okay, are you here or are we someone here because you or they have NF1, NF2 or schwannomatosis?
We need a D, all of the above.
Oh, yes. I didn't. I didn't consider that some people have multiple of these conditions in the same family. But if you look at the numbers, there's 7 billion people in the world. 1 in 3,000 is NF1, 1 in 30,000 or so is NF2. So there's a lot of zeros there, but it's something like 1 in 90 million is your chance of having both NF1 and NF2 in your family, which is pretty uncommon. I might have added an extra zero there, but there are a lot of people in the world, so it's not unheard of. So predominantly patients and people are here today because of NF1, and there is a significant minority of NF2. We don't have anyone here today, according to this poll, with schwannomatosis. This reflects the numbers we see in our clinic. So we probably manage 400 plus patients with NF1, 20 plus patients with NF2. We're skewed very paediatric because it's a paediatric service, so most NF2 patients don't present to their late teens or 20s. So that's reflective, and these numbers bear out in the incidence and prevalence figures of neurofibromatosis. We don't currently manage anyone, to our knowledge, with schwannomatosis in our clinic at the Children's Hospital. Can I go to the next slide, please? Oh, I have to... Does that come up on your slide when you see that? Do you get a list of potential answers? No list? Ah. No? Okay. I think we'll skip that question. Wait, just give me 1 second. Oh, there we go. Oh, this is a word cloud. I'm not sure if I should have used a word cloud for this because it's slightly confusing, but it does give you a vibe that we're capturing a big, broad range of patients. I can see there's a 3 there, and I can see there's 51 being the oldest. Someone wrote old, which... At dinner last night, we were discussing what old was. That back in the day, you got to retire on the pension at 55. No one would consider 55 old anymore. So I'll take old as older than 43, which is my age. So someone put NF1 in as well. Yeah, so this reflects the fact that NF1 and NF2 patients are any age. Oh, there's more coming. Or is it just dancing around on its own? I think it's just dancing around on its own. We'll go to the next slide. Okay, what state are you in? Oh, so we know from, and I'm sure you're all aware of this, NF1 has the same rate of incidence anywhere in the world, which is approximately 1 in 2.5 to 1 in 3,000, and F2 is thought to have the same rate of incidence and prevalence anywhere in the world, which is about 1 in 30,000. We know that, as well as that, we should see most of our patients from the eastern seaboard. I don't know if they're stretched out. I think it's too early in Perth to be watching this currently. But we expect most of our patients to live where most of the population is, and that's just a reflection of the population in Australia is skewed onto the eastern seaboard. Can we go to the next slide, please? Okay. Do you go to an NF clinic? So in Melbourne, we have an NF clinic a designated NF clinic at the Royal Children's and the Royal Melbourne. We're in discussion with the Austin Hospital about opening up an NF clinic there. I imagine that is still a work in progress to cater, to make the service more geographically broad and to also take advantage of the expertise that's in that part of the state health system. And also because there are a lot of adult patients with NF1, and I think having them all run through the Royal Melbourne might not be viable as the future goes. In New South Wales, there are designated NF clinics, Westmead Children's Hospital, which see patients up into the age of 18, and then at Royal North Shore Hospital that see both paediatric and adult patients, and they have general NF clinics, complicated or complex NF clinics, and skin NF clinic. NF2 care is more dispersed through both states. There's nothing designated in Brisbane, Adelaide or Perth. And Tasmania, we see a few patients from Tasmania. So yeah, I think we cover the north of Tasmania. I don't know what happens around Hobart. So 2/3 of the patients or patients' families who attend today do go to an NF clinic. A third don't, so that's closer to a fifth don't. So the message is, if you don't currently attend an NF clinic and you want to, please be in touch with us via the CTF. Alternatively, you could get your GP or your paediatrician or whoever is taking care of your medical care to provide a referral into the hospital. If to the children's, you can address it to me, Gabriel Dabscheck, neurology, Royal Children's Hospital. If you're an adult, Kate Drummond, Royal Melbourne Hospital, NF Clinic. Kate's always thanking me for growing her clinic. Go to the next. Is that a blank slide? We'll go to the next one. Or could I, if you escape? Was that one? Was there a 6? Okay. Where do you get most of your health information about NF from? So, I know when patients come and see us in clinic for the first time, they do know everything I'm going to tell them because they've got a lot of information. And I sometimes ask, and I often don't ask, I just assume. But I never really know where people get their information from. I just assume that people go onto Google and start Googling, or they ask a family member, or they go to Facebook. But yeah, this question is mainly for me, because I don't actually know where people get their information from. And because this is anonymised, you can tell the truth. There are no incorrect answers. I've lost the mouse. Thank you. Well, the team from CTF is clearly doing something right. Hopefully you're paying for Google AdWords or for search engine. Are you paying or are you getting it for free?
Google Ad free.
Oh, good.
But also most of it's SEO.
So, yeah, so I have not Googled neurofibromatosis in a while, but I take it that the CTF end up very high on a search from anywhere in Australia, which is fantastic to hear. It's good that you get some information from our clinic. It's humbling that we come in second as a source of information, and only 6% get information from social media. So that's reasonably impressive. Can I go to the next slide? Oh, this is a word slide. I'll play Carly. I have a question from the audience. I would throw you a microphone, but I might break it.
It's not actually a question, but it's a little disappointing. It's not actually a question, but I just thought it was disappointing that we maybe only 3% of us are getting any information from our GPs. So maybe they need more education. Maybe next time you go and visit your GP, you might be able to direct them towards the CTF or the health pathways that I might discuss later. So just putting that out there.
Thanks, Carly. I think there is a fundamental problem in the Australian healthcare system when all you hear about is how much stress, how much pressure the GPs are under. And like, how as a consumer are you expected to really want to go to a GP when all you hear about is bad things about what's happening with GPs? That's not a topic for today, but I thought I'd throw it in there. So this is the current question. What is your biggest fear related to NF1, NF2 and schwannomatosis? I really should have read the instructions because I'm not sure what the size means. Oh, so multiple people written in the future. Okay. So the big things, thank you, Renee. Future, progression and disfigurement. Discrimination, opportunities, conditions, something. So, the future really comes up. And I guess, it's hard to tease that out without directly asking people, but I can guess what that means. And I think part of the future is uncertainty about what happens with different complications of neurofibromatosis, be it NF1 or NF2. With NF1, it's about tumour growth and progression, the chance of malignancy, the potential burden of the cutaneous neurofibromas, educational work opportunities. As we give people more of an opportunity, this page is really filling up. Some people wrote teenage, as in, so again, it's hard to really tease that out. The fear of the unknown is something that comes up. And, this really speaks to the uncertainty of living with the tumour predisposition condition. There is a lot of research happening and quite a little bit of clinical progress. The most significant clinical progress over the last 5 years have been MEK inhibitors, and Alexion should hopefully have selumetinib through the PBAC sometime in the next 12 to 24 months. That looks, I actually think that's going to happen. That's probably going to be the most transformational thing that's happened in the for NF patients for ages. I can't think of anything more transformational aside from genetic testing going back 20 years, which would be great for a subset of NF patients that have plexiform neurofibromas that are causing harm. And harm will, is currently the indications for MEK inhibitors are disfigurement or major organ function being threatened. As time goes by, there'll be a loosening of those criteria, either formally or informally. Other things that have happened recently, and the Children's Tumour Foundation to thank for this as well, is there's now a rebate for IVF and pre-implantation diagnosis for NF1. So if you have NF1 or NF2, you have a 1 in 2 chance of your child having NF1. And depending on your experience and your view of your future child's experience, you can go on then to have IVF. And IVF is very costly. It costs in the tens of thousands of dollars, and now there's a rebate. So that's something that's going to change the clinical practice and a lot of the decision making for both mothers and fathers with NF1. We heard yesterday from Gareth Evans, who is the professor and the UK clinical lead of NF2, showing that over the decades, the survival of NF2 has really increased. So it was quite dramatic figures that the population of NF2 diagnosed since the 2010s is now approaching what the age-matched peers are, which is very different to the cohort of patients diagnosed in the 1990s. So as time goes on, there will be more coming. There was another compound that was published last year, not a MEK inhibitor, a second different agent acting on that same pathway. And in the future, there'll be publications of both together, and there'll be more drugs coming. There is a lot that's come up. I think we'll go on to the next question. This is a NF1 question. You can answer it if you've got NF2. What would you like to see more from in the NF clinic? And this is both the NF clinic, across all NF clinics, through the Children's, through the Royal Melbourne, through Westmead and through Royal North Shore. I think the internet's broken.
Voting hasn't been turned on.
Oh, damn computer. I've got to go to the computer. Yeah, I did do a trial run at home, I want to reassure you, especially you, Carly. And it worked. So in terms of, I can speak to most of these points. In terms of more trials, most of the research comes out of the US and the UK. The NF consortium, that are mainly US-based, have rounds and rounds of trials. We are a trial site on paper. We struggle to get drug into the country, and COVID has made that, it's just put a spanner in the works. We always do put our hands up. So there will be more trials coming. Our access to them is always questionable because mainly most of the stuff comes out of the US. There are local trials. Our neurocognitive team has a very strong trial arm, and they'll be continuing to bring more trials to our clinic and potentially to the adult clinics. In terms of more treatments, the surgical treatment's pretty mature as a concept. The medical therapies are going to continue to come. It will be different when you don't have to get compassionate use or be on a trial to access a MEK inhibitor. So that's going to change, hopefully in the next 2 years. There will be other agents coming out. There will be dual therapy, and it's really a wait and see box. We do want more nurses in the clinic. I am constantly telling my boss that I want more staff in my clinic. So this will happen. You just will have to bear with us while it does happen. We go to the next slide, please. This can be either. Who do you contact when you have a medical issue? So in an ideal world, I'm not sure what the answer to this. In an ideal world, would be adequately staffed that would have someone at the end of the phone that could triage your phone calls, that could say, yeah, that sounds like a GP problem. Or yeah, you should come back to clinic. We're probably 2 years away from having something like that, at least at our clinic. I understand that the Royal North Shore model has something more like that. So I think this is reflective of what should happen and what is happening. We go to the next slide, please. Oh, this is a question for that, was it 23% of patients with NF1? About what is the biggest issue for you right now? So with NF2, this was an NF2 question. I'm not getting any responses. There, yeah, vestibular schwannoma. So VS stands for vestibular schwannoma. They're the nerves that grow, the tumours that grow on the ear nubes. They typically start growing in your teens, and they do cause hearing loss, and they can compress the brainstem and the brain. So hearing is something that really comes up. In terms of access, so I'll address the big issues one at a time. Hearing is a big issue, and that's related to management of the vestibular schwannomas. In an ideal, well, what should happen, and this talks to access, is that patients should be linked in with a clinic like ours or regular audiology, NF2, discussed at a multidisciplinary clinic, and then have a decision about the best management. Often there are no good choices, and that's something that is acknowledged by everyone, and the decisions are very difficult. One thing that's come on board in the last 12 months is that Avastin, or the generic of Avastin, has joined the PBS. So that's now accessible to adult patients, because previously, at least in our facility, our hospital will pay for it, but the adult hospitals wouldn't. So that's been a major, not necessarily breakthrough, but a small to medium-sized step for the management of these patients. There have been new agents trials and published that show that they work for meningiomas, but not so well for vestibular schwannomas. So that really speaks to our understanding. The one thing that we could do better is improve access, and that's something that we are working on. We are working on having some designated NF2 days, because our NF1 population is so much bigger. We don't want to get our NF2 patients lost amidst our NF1 patients, so we can have all the relevant NF2 specialists in the room, either every 12 to probably every 6 to 12 months. So we're going to start that next year in April. Thanks. We'll go to the next question. This is a very specific question for like 3 people in the audience. Was this my last question? I guess we'll find out. This is my last question. Yes, so if you are that one person, that's better. The answer is yes. You should be linked in with someone, because you need to be. Who's doing the voice to text?
There's a guy.
He is excellent.
Yeah.
It's really amazing. So my eldest son is 11. I'm going to run down the clock. My eldest son is 11, and he watches TV with the subtitles on. And then I read somewhere that he's not a millennial, but all the millennials, 80%, watch Netflix or whatever with subtitles on. And it's totally beyond me. Sure, I understand if you've got hearing, my dad's deaf, and he watches with the subtitles on because he can't hear. I find it incredibly distracting. But anyway. But these are really good subtitles. So that is, I've got a minute to go, but that was my last question. We will throw now to Q&A.
Thank you. Hi, Gabby. I just wondered, it was just a question about trametinib and the side effects that can occur. And I just wondered if there was any new development of compounds that are similar to trametinib but slightly different, that reduce the likelihood of those side effects, whether there's any sort of new similar drugs to trametinib on the horizon with less toxicity.
So you can hear me okay? With trametinib. So trametinib is a MEK inhibitor for the people in the room but are not familiar with it. It's used in the treatment of plexiform neurofibromas, and more than 70% of patients have reduction in their tumour by more than 30%, and it often takes more than 12 months until you see a good response. About 1 in 10 patients will stop them on trials, and the major side effects are skin-related. So you can get an acneiform rash, you can get quite bad paronychia, which is infected toenails. A few patients stop them because they have gastrointestinal symptoms, so they get an upset stomach. They're the main reasons in trial why people stop them, which does mean that 90% of patients through the trials continue on them. That really has been our clinical experience as well, that we've had to stop a few kids, but the vast majority continue. There are other agents. I can't pronounce what it's called, crosinetinib or something like that. There's been one publication where it's not as effective. It's 50% have a partial response rather than 70%. I know that Mark Fisher from who leads up the Big NF research group was talking about combination trials to see where that ends. In terms of trametinib, there's in other use, as in not in NF, in melanoma and different malignancies. When you combine it with other agents, it does cause less side effects. That's just something that has not been, and probably won't be done in NF.
And I just had one follow-up question, if that was okay. I just wondered if there is an extreme reaction to trametinib at a particular age. So, for instance, the person is 18 years old, has a bad reaction, needs to cease. Is it worthwhile coming back at a later time in their development? Is there any sort of connection between the age of the person and the reaction?
I don't know I do not know the answer to that. I know that patients are often stopped and restarted, like re-challenged, and they end up having the same reaction. We've just switched one patient from trametinib to selumetinib because they had a bad skin reaction to the trametinib. So that's always an option as well, that there are different MEK inhibitors, and that was done very purposefully by the NF research groups. They backed many horses, not wanting to put all their eggs in the one basket.
Thank you.
Questions? No. Thank you, Dr. Dabscheck.